Drgaboneqhsc.
Good morning, good evening. Welcome to QHSC Health Series. Today we're going to discuss about diabetes and diabetes as a pregnancy guide for healthcare professionals. And we're going to welcome Ms. Nancy Lintner, and she's going to give all the credentials herself. But we're just excited to see her providing this much needed education. Ms. Nancy has been diabetic educator for a long time, and I think her contribution to nursing and global health is much needed right now. And we are hoping that at the end of this presentation, you should be able to learn what, especially for United States, what we do for our pregnant patients, and also for Tanzania and any other country. You should be able to work towards gaining this knowledge to be able to develop some clinical practices, standard of practices and guidelines for our pregnant patients when they receive this diagnosis. So we are so excited that she is able to spend this Saturday with us to share this knowledge. And then we welcome all the questions once we send this recording. We welcome all the questions through drgaboneqhsc@gmail.com. Those information will be at the end of the presentation. If you have any questions specifically for Ms. Nancy, then we welcome those questions. And then we schedule a discussion follow-up so we can have Ms. Nancy and all the global experts to come and discuss how we can build or collaborating clinical practice in other countries. So thank you very much, Ms. Nancy, and welcome to QHSC Health Series.
Thank you, Harriet. Good morning, everyone, and maybe good evening, everyone. As Harriet said, my name is Nancy Lintner, and I feel honored to be invited to present for this medical mission. My connection with Harriet is that we used to work at the University of Cincinnati in Cincinnati, Ohio. She did education for our women's or maternal child population, and she helped me make contact with the nurses to help them improve their skills in terms of taking care of pregnant women with diabetes. So the first thing I would like to discuss is our objectives today. And we want to review the definitions and diagnosis of gestational diabetes, type 1 diabetes and type 2 diabetes. We are also going to define how to adequately control the patient's blood sugars during pregnancy. We would like to also talk about glycemic control for the type 1 and type 2 patients that are pregnant with diabetes, and then also glycemic control for our patients that develop gestational diabetes during pregnancy. So we are going to start with discussing the definitions of diabetes, and as many of you already know, that it is a metabolic disease, all characterized by impaired glucose utilization and resulting in hyperglycemia. With type 1 diabetes, which is no longer known as insulin-dependent diabetes or juvenile onset diabetes, it accounts for about 5% of diabetes. The pancreatic beta cells have been destroyed. For some reason, we have found that many of the patients during childhood, they contract some sort of illness which affects the pancreas. There's absolute deficiency of insulin with type 1, and then exogenous insulin is required for the survival and to prevent diabetic ketoacidosis, which can be life-threatening. For type 2 diabetes, it's no longer known as non-insulin dependent diabetes or adult onset diabetes. This accounts for 95% of all diabetes. It's associated with obesity and having a sedentary lifestyle. It's characterized by insulin resistance and a relative insulin deficiency in the pancreas. It's managed by diet or meal plans, physical activity alone, or with oral agents or insulin. Let's see. So let's talk about gestational diabetes, which is another form of diabetes diagnosed during pregnancy. Gestational diabetes is defined as impaired glucose tolerance and utilization of insulin during pregnancy. This accounts for 90% of diabetes during pregnancy, first recognized during pregnancy and best controlled with medical nutrition therapy or meal planning, scheduled physical activity, plus or minus oral agents or insulin for optimal glycemic control. It is a risk factor for developing diabetes mellitus after pregnancy, and that risk factor can be as high as 50% after 10 years. This diabetes outside of pregnancy is defined as prediabetes. It's in the non-pregnant population, and that definition is going to be either impaired fasting glucose, which is a fasting value of greater than 100 or less than 126, or impaired glucose tolerance, which is a blood glucose greater than 140 and less than 200 milligrams per deciliter after a 2-hour 75-gram glucola. The risk factors associated with having diabetes before pregnancy are that the patient or the fetus can have major congenital abnormalities, which is the leading cause of perinatal mortality as much as 6 to 12%. This many times happens if the A1C is greater than 10% entering into pregnancy. It's associated with poor glycemic control, increased risk of stillbirth and fetal weight above 4,000 grams. Patients with type 1 and type 2 diabetes have similar risks. And then there is going to be a higher risk for cesarean section, preterm labor, and preeclampsia. Here is the White classification, which was developed by Dr. Priscilla White in 1949. Please review the table at your convenience. The categories are going to be A1, gestational diabetes, A2, gestational diabetes. A1 is going to be glycemic control with meal planning. A2, gestational diabetes. The woman is going to either need oral agents or she's going to need insulin. We try to help the woman with her meal planning. And the other categories associated with onset of diabetes is the eye and kidney and heart disease, or eye disease that requires laser treatment and or any history of kidney transplant. So let's now discuss screening and diagnosis for gestational diabetes. If we are thinking or suspecting gestational diabetes in early pregnancy, which would be less than 20 weeks, we're going to look at these risk factors at the first prenatal visit to rule any of this out. So the high risk indicators are going to be physical inactivity, any previous history of gestational diabetes, having a baby that is greater than 4,000 grams, or history of stillbirth, a mother that had a history of hypertension, a blood pressure of 140/90, or any treatment of hypertension or cardiovascular disease. She will have had a history of cholesterol less than or equal to 35 milligrams per deciliter, deciliter, or she will have a history of a fasting triglyceride of greater than or equal to 250 milligrams per deciliter. Any history of polycystic ovarian syndrome, acanthosis nigricans, non-alcoholic liver disease, any morbid obesity, etc. Any history of an A1C greater than 5.7, which is going to be pre-diabetes, impaired glucose tolerance or impaired fasting glucose, or if there's an A1C greater than 6.5, we are going to diagnose this patient at less than 20 weeks of having pre-gestational diabetes. There's also a risk factor if she has a first-degree relative with diabetes mellitus. That would be the parents or any sisters or brothers, or an ethnicity of African American, American Indian, Asian American, Hispanic, Latina, or Pacific Islander. And these are all discussed in the ACOG practice bulletin of 190, and that would be the American College of Obstetricians and Gynecologists. This is the criteria for early diagnosis in pregnancy from the American Diabetes Association and the International Association of Diabetes and Pregnancy Study Group. At the first prenatal visit, we want to measure the fasting plasma glucose, or the A1C, or a random plasma glucose. So if the fasting plasma glucose is greater than 126, we have a diagnosis. If the A1C is greater than 6.5, we have a diagnosis. Or any random plasma glucose, which is greater than 200 milligrams per deciliter. One of these criteria must be met to identify a patient of having overt diabetes. If the random plasma is the initial measure, the tentative diagnosis overt in pregnancy, and it should be confirmed by following up with a fasting plasma glucose or an A1C using the DCT UK PDS standardized assay. This method has not been adopted by the American College of Obstetricians and Gynecologists. There are different ways to screen for gestational diabetes. One of the ways supported by the American College of Obstetricians and Gynecologists is the two-step approach. The two-step approach is going to be a non-fasting 1 hour, 50-gram glucose tolerance test. Women should have 3 days of at least 150 grams of carbohydrates, and the test should be performed before 9 a.m. The patient should remain seated. She should not smoke. We are going to get a venous sample then 1 hour after the start of ingesting the glucola. The upper limit of threshold after the 50-gram glucola load is going to be 140. You want to perform a diagnostic 100-gram 3-hour oral glucose tolerance test on a separate day for the woman who exceeds that threshold of 140, meaning that she failed the first step of the two-step. If the venous blood sample is going to be greater than 126, or the challenge is greater than 200, do not proceed with the 3-hour oral glucose tolerance test. The diagnosis is confirmed. We were concerned that if we fed a patient with undiagnosed type 2 diabetes, that we would make her sick. If we are going to use the one step, which is not supported by the American College of Obstetricians and Gynecologists, at 24 to 28 weeks, we're going to perform a 2-hour 75-gram oral glucose tolerance test after an overnight fast. She will fail this test if one or more values have exceeded, and it will confirm the diagnosis of gestational diabetes, and that would be a fasting plasma glucose of greater than or equal to 95, a 1-hour plasma glucose of greater than or equal to 180, a 2-hour plasma glucose of greater than 155.
I have a question.
Mm-hmm.
So why was ACAG does not support this one-step approach?
Because it causes so many diagnoses. And
Okay.
it would be difficult to care for all of these women. Many of the women that are diagnosed using this method, what I have found, they are able to keep their blood sugars under control if they're following the meal plan. They don't require medicine.
Okay.
So it overloads the system. Yes, here it says the ones that result in increased diagnosis of gestational diabetes.
Okay.
So let's talk about assessment to help the patient better manage their diabetes. There's many patients who have type 1 and type 2 diabetes that are depressed because of their illness. So there are 7 healthy behaviors adopted by the Association of Certified Diabetes Care and Education Specialists. And one of these behaviors is healthy coping. Healthy coping means having a positive attitude toward diabetes and self-management, as well as positive relationships with others. Therefore, assessment is an important to rule out the psychological stress. We use the Edinburgh postnatal depression scale to rule out psychological distress. And as you can see, if a patient has anxiety, depression, ADD, or ADHD, bipolar illness, childcare stress, eating disorders, lack of family, financial, and social support, we should investigate their psychological distress. We use motivational interviewing, and as I said before, the EPDS during the 2nd and 3rd trimesters, and then at 6 months postpartum. And then again, 3 months postpartum is also recommended. Our low-income pregnant women with diabetes experience the greater chances of perinatal and postpartum depression and are underdiagnosed. I want to discuss medical nutrition therapy, which is the healthy behavior, 7 healthy behavior of healthy eating to improve blood glucose control during pregnancy. The goal of medical nutrition therapy is to provide enough calories and nutrient requirements for the woman to sustain a healthy pregnancy. We referred our patients to a dietitian at the very first visit for an individualized medical nutrition therapy plan. We did carbohydrate distribution meal planning, at least 175 grams of carbohydrates divided into 3 meals and 3 snacks. And we encouraged them to eat these meals and snacks on time to improve blood sugar control. And the calories are going to be based on the estimated energy requirement formulas for each trimester. And then we adjust according to maternal parameters and optimal weight gain for pregnancy. And then we teach the women how to count carbs and read food labels. And then the meal and snack regimen should be individualized for women using continuous subcutaneous insulin infusion pumps. But I understand that you do not use those with your pregnant women. So here are the grams of carbohydrates and for meals and snacks. We recommend for breakfast, we would do 2 servings of carbohydrates, which would be 30 grams. The mid-morning snack, which would be 2 to 3 hours later, would be 1 serving of carbohydrate, which is 15 grams. And then at lunch, we're going to do 45 grams, which is going to be 3 servings. Mid-afternoon snack is going to be 1 serving at 15 grams. And then at dinner, we're going to do 45 grams, which is going to be 3 servings. And then for the bedtime snack, we're going to do 2 servings of carbohydrates at 30 grams. Here is an 1,800 calorie meal plan. And again, we promoted that the patient ate every 2 to 3 hours apart. And the reason being that we wanted them to eat on time is if they went long lengths of time between meals and snacks. We were concerned that the liver was going to dump sugar into the bloodstream. And if the blood sugar is already high, the patient is sort of in the starvation mode, then it's going to make the glycemic management more difficult to control. And I would go to you for advice on the types of foods that the women in Tanzania eat, so that it is individualized and we don't feel like she's, eating foods that she doesn't like to eat, so to speak.
Yeah, I agree with the sample you provided. So definitely for people in Tanzania, we have to tailor to what is available for them, what they can afford, and what they're able to consume each day or each meal. So definitely we have to adjust that. But at least you provided a sample which we can mirror and then be able to count those calories and guide them to the right path for what is available individually. So that sounds great.
I think that the things that we have found is that patients that have type 1 and type 2 diabetes are eating carbohydrates by themselves instead of pairing protein and carbohydrates together. And when you eat the protein with the carbohydrate, it actually slows down the release of the sugar into the bloodstream, which improves the glycemic control. So if there's a way that you could tailor a meal plan where the patient is always pairing or marrying the protein with the carbohydrate and doing the proper carbohydrate count, and then the timing of the meals. We used to have our gals do, like breakfast at 8, snack at 10, lunch at 12 or 1, then snack at 3, then try to eat their dinner at 6, and then maybe have a bedtime snack around 9 o'clock at night. We really didn't want them eating their big meal of dinner past 7 o'clock at night, because then that had a tendency to increase the risk of fasting hyperglycemia during pregnancy. And here is a serving size chart. If some of the gals are eating, more than 45 grams of carbohydrate at the meal, it's going to be difficult for her to control her sugars as well. We normally recommend protein of 3 ounces. A half a cup would be 4 ounces for the vegetables, starchy and non-starchy, or I don't know whether they eat macaroni in Tanzania. The 1 cup is going to be 8 ounces, and then 2 tablespoons is going to be 1 ounce. But it would help them better control their blood sugars if they're watching their portions. So let's now talk about monitoring the patient's blood sugars. The blood sugar targets for pregnancy are going to be the fasting and before lunch and dinner is going to be between 60 and 95. Then 1 hour after she starts eating the meal, it's going to be 140. If she forgets to test at 1 hour, or you want her to test at 2 hours, it should be less than 120. After the start of her meal. And then the pre-bedtime snack blood sugar before sleep is going to be 60 to 95. And then if she ever needs to do a 3 a.m., maybe concerned of a low sugar, it should be between 60 and 95. And this comes from the American College of Obstetricians and Gynecologists Practice Bulletin of 190 in 2018. Of the other 7 healthy behaviors is going to be physical activity to improve glucose metabolism. So what we would teach our patients is we wanted her to exercise at least 30 to 60 minutes a day to increase the insulin sensitivity and her lipid metabolism. I had seen some research that if the patient exercises 30 minutes after the dinner meal, it actually improves her blood glucose 1 to 2 hours after the dinner meal. And then it improves her blood glucose before she goes to bed at night. And then ultimately it may improve her fasting blood sugar the following morning. She can divide her sessions between 10 and 20 segments 3 times a day if she wants to. If she's taking insulin, she probably should monitor her blood sugar before, during, and after her exercise. And, you know, I don't know whether she would have a glucometer available, but maybe take a protein carbohydrate snack with her if she's going to exercise, if she worries about low blood sugar as a type 1. Her blood sugar, if her blood sugar is less than 95, we do want her to take a snack to prevent low sugar. Her maternal heart rate should be less than 140 if she's not physically active, and less than 120 if she is. We have had type 1 patients wear ID bracelets, and we tell them not to exercise with a blood sugar greater than 200. Or if she's dipping her urine for ketones. Dipping for urine seems to be an old practice, but it really is helpful with the type 1 diabetic, because if she's got moderate to large ketones, she could be headed to DKA. We find it's very important to evaluate the patient's medication regimen coming into pregnancy for the pre-gestational patients with type 1 and type 2 diabetes. They should not be taking ACE inhibitors or angiotensin II receptor blockers. They're contraindicated during pregnancy. The safe alternatives are going to be nifedipine or Aldomet, which I believe is Procardia. And then we don't want her taking any lipid-lowering medications because they are also contraindicated in pregnancy. Type 1 and type 2 patients are going to be a high risk factor for preeclampsia. And most recently, I discovered that ACOG is now recommending low-dose aspirin, 81 milligrams a day, to maybe reduce the risk of preeclampsia during pregnancy. And that aspirin can be taken between 12 and 28 weeks. Here is a maternal testing protocol for patients that have type 1 and type 2 diabetes. I'm going to let you go over this table, and then if you have any questions in our question and answer session, I will be happy to help you. And then we've got a fetal evaluation table for type 1 and type 2, and also gestational diabetes. And again, we can talk about these testings and which trimester is appropriate for any of these testings. You, ladies and gentlemen, all know there's going to be increased insulin requirements during pregnancy. Insulin requirements generally will increase between 50 and 100% with advanced pregnancy beyond 24, 28 weeks. The other factors that are going to increase the insulin requirements are going to be obesity, any body mass index greater than 30. The patient may actually need up to 1.2 units per kilogram of insulin because of this obesity. Sepsis or infection will cause blood sugars to rise. Steroids with beta-methazone or prednisone will increase the blood sugars, and then any tocolysis with beta-mimetics. So all of this should be taken into consideration when reviewing blood sugars from day to day. Here are is a graph that I got from Mary Beth Interisi. She was the program coordinator at the University of California, San Francisco, and a great mentor, teaching me how to help manage pregnant women with diabetes. You can see, where the insulin requirements are between 5 and 10 weeks, and then how high they climb throughout the pregnancy. Here is how to dose insulin during pregnancy. It's going to be individualized based on the type of diabetes, blood glucose control, and the gestational age. We teach our nurses in the hospital and our patients in the outpatient setting that it is best to inject in the subcutaneous tissue in the abdomen or the belly. We teach them to rotate their sites 2 inches away from the belly button, and then also 2 inches away from the last site, because if we keep injecting into the same site, the insulin stops working. So you can see at what week gestation, how many units per kilogram the patient is going to need. And it will, as you know, increase until they get to 36 or 40 weeks. And then there's the formula, how to calculate it. Next up is going to be commonly prescribed insulins. So we've got rapid acting insulin, which is what we used, Humalog or Novolog, depending on what the insurance covered. I understand these women don't have insurance. Then there's the short acting, regular, and we use that for IV infusion when they're in the hospital. We didn't use regular insulin in our outpatient practice. Then we've got the intermediate acting, the Humalog N and the Novolog N, and we prescribe that twice a day, before breakfast and then before bedtime. And then there's the long-acting insulin, which is the Lantus. Now, we did not use the Lantus. Maternal fetal medicine doesn't recommend the Lantus because Lantus generally will not address the Dawn phenomenon. So we always used the Humalog, Novolog, and NPH.
Yeah, so for Tanzania, some women may have insurance, but majority of them don't. And that's an issue for maintenance of that medication or the disease process. So that's the challenge now we are hoping someday to address.
We stopped using the regular insulin because it doesn't act fast enough. But certainly if patients don't have money, and I don't know what pharmacy could help you, but the regular insulin could be used 30 minutes before each meal, and then the NPH could be used before breakfast and before bedtime. You wouldn't necessarily have to use the Humalog and the Novolog. I know it's very expensive. We were using syringes and insulin syringes and vials because our maternal fetal medicine specialist felt that there was less error using that than using pens. I know that the pens are much more expensive than using the vial and the insulin syringes.
Yeah, and then just heads up for the insulin, because it has to be kept in a cool place or refrigeration. So there is some challenges for people in Tanzania. Some of them might not have those facilities to support or keeping the insulin safe in the refrigerator. So that could be another challenge for a person from the village to be able to get access to the insulin and later on protect or preserving it to make sure it's safe for her to use during the pregnancy.
Yeah, we teach the patients that unopened insulin must remain in the refrigerator. It should not be less than 32 degrees, meaning subject to freezing temperatures, and then we don't want it any higher than 85 degrees. Now this is unopened, but once it's opened, it can remain at room temperature until all of the insulin is used.
Okay.
So that does sound like a big challenge. If they're getting a 30-month supply, how are they going to keep that unopened insulin in refrigerated?
That's true.
Okay. So I threw this slide in. It just demonstrates the patient's needs according to weight. If we got frustrated with their insulin to carb ratio for their meals, this is for the type 1 patient with diabetes, then we would look at this table and say, well, this patient weighs 220 pounds. she's going to need 1 to 7 or 1 unit of insulin for 7 grams of carbohydrates versus, this underweight patient that weighs between 100 and 109 pounds that only requires 1 unit of insulin for 16 grams of carbohydrate. So, if you get stuck on trying to figure out why the insulin's not working, maybe consider the weight of the patient. So here's another pocket guide that we had for adjusting insulin, and this was in the inpatient setting. If the patient's blood sugars were not well controlled, during the day, we would, it's like a sliding scale, but it's really a pre-meal adjustment algorithm. We didn't use sliding scales because many times sliding scales are used when patients already have active insulin on board, which can really increase the risk of hypoglycemia. But you can see here are the blood sugar values, and then here is how many units of insulin we would give to try to correct severe hyperglycemia in the hospital setting.
Okay.
Usually the active insulin curve is going to be 3 to 4 hours. So we would never want to give a patient insulin an hour or 2 hours after they have insulin on board. We're going to discuss hypoglycemia management. And this is basically the rule of 15s. We would not treat a blood sugar that's greater than 60 because this could result in rebound hyperglycemia. We always want to ensure that the patient is eating the meals on time, 2 to 3 hours apart, and not skipping meals because that can become a problem. We teach our nurses not to treat a low blood sugar if the patient says she has low blood sugar. We always want to get a finger stick to make sure that the blood sugar is less than 60. We do not recommend complex carbohydrates such as milk, cookies, candy, peanut butter, crackers, or sandwiches, as this is going to delay the response because there is fat in all of these products. So it's going to slow the absorption of the glucose in these products. So we recommend 4 ounces of juice. Some people don't recommend orange juice during pregnancy, but we used apple and orange juice to try to help. Or we could use 4 glucose tablets with 8 ounces of water. And then we would have the patient, or we as staff members would retest the blood sugar in 15 minutes to make sure that the blood sugar is higher than 60. And then to keep that blood sugar higher than 60, that's when you can offer the patient a sandwich or a peanut butter crackers. I don't know that I would offer them cookies or candy. Milk, 8 ounces of milk would sustain that normal blood sugar. This slide is going to address hypoglycemic management and then also the rule of 15s. This is more for the inpatient setting. You treat with 15 grams of carbs, recheck the blood sugar in 15 minutes and expect the blood sugar to rise by 15 points. If the blood sugar is less than 60, we're only going to give 1 serving to get that blood sugar back up where it needs to be. If it's not back up, then you want to repeat with something orally. It's helpful to know that the blood sugar is greater than 60 times 2, and then the patient can go on about their day. If the blood sugar is less than 40, we usually ask the patient or treat the patient with 2 servings of carbohydrate. So that would be 8 ounces of apple juice, or if you don't have apple juice, maybe orange juice. And then we're going to recheck the sugar in 15 minutes and make sure that it's greater than 60. And then we would feed the patient half of the sandwich or some peanut butter crackers, to sustain that blood sugar. Some of the type 1s, you can get the blood sugar up to greater than 60, but then they fall back down below 60. So it's really important to feed them once you get to that ideal blood sugar. With the patients on conscious or unresponsive and can't take any oral agents to treat the low sugar, we give glucagon 1 milligram stat, either sub-Q or IM, and that should raise the blood sugar by at least 135 points. Now, this may make the patient sick, so you're probably going to want to turn the patient on the sides because some of the patients vomit after they have the glucagon. Just keep monitoring the blood sugar until she gets to the ideal value. If you can't get the blood sugar to normalize, then I would be prepared to start D5 normal saline at 125 milliliters per hour if the blood sugar is remaining. It says less than 20 here, but I would be more inclined if it's less than 40. So let's discuss oral agents for gestational diabetes. In the US at the University of Cincinnati, we used all three agents, glyburide and acarbose. Glyburide is a second generation hypoglycemic agent, and it treats the post-meal blood sugar. And then it wasn't used in the US until the year 2000. It was Oded Langer that did the research study about the safety using glyburide during pregnancy. I actually got to meet Oded at a diabetes and pregnancy conference in New York City. Then the other agent that can be used is metformin, and it has been used in early pregnancy for polycystic ovarian syndrome, but it's really not recommended as the first line of oral agent therapy. This agent has been shown to be less effective and higher failure rate, and has less available safety data in pregnancy than glyburide. This crosses the placenta, and but there is low risk for congenital anomalies. The Acarbose is something that we used. It's an hyperglycemic agent, which is particularly useful to treat post meals also. There's limited research suggesting that Acarbose is safe and more convenient, and it's less expensive. So maybe this would be an agent that you guys could investigate to help your pregnant women with diabetes. Pregnant women taking oral agents should continue their meal plan, physical activity, monitoring their blood sugars, and then have the same maternal fetal surveillance as the women taking insulin. If the patient doesn't achieve glycemic control, then with the maximum doses of the oral agents, then we would transition these patients to insulin therapy. ACOG recommends that insulin remain the first treatment of choice for pre-gestational type 1, type 2, and newly diagnosed diabetes at less than 20 weeks. Here are some research trials on glyburide. And like I said before, this was Dr. Oded Langer that did this in the year 2000. He compared glyburide to insulin in women with gestational diabetes. 404 pregnant women or individuals with gestational diabetes were randomized to the management with glyburide or insulin at between 11 and 33 weeks. The ages of the patients were between 18 and 40. For the glyburide, there were 201 patients, and for the regular insulin, there was 203 patients. These were used for patients that failed dietary management. Their fastings were greater than 95, and their post meals were greater than 120 at the 2-hour mark. Here are some maternal outcomes related to glyburide and insulin. There were 164 patients. Failed treatment was with 4% of the patients. They were switched to insulin. And then treatment with insulin, 179 patients were 88% within target. The maternal outcomes for preeclampsia for glyburide was 6% and insulin was 6%, so no difference. And then for the need for cesarean delivery, the glyburide was 23% of the patients and insulin was 24% of the patients. So this is really good data, good safety data. For the neonatal outcomes, in terms of large for gestational age or macrosomia, there were no significant differences in the two groups, and glyburide was not detected in the cord serum of any of the infants. So this is good safety data as well. Here is the MIG trial. The MIG trial, which stands for Metformin in Gestational Diabetes. It was a prospective randomized multi-center trial in women with gestational diabetes, testing the hypothesis that metformin compared to insulin is associated with similar perinatal outcomes and improved markers of insulin sensitivity in the mother and the baby. So there were 750 women with GDM at 22 to 33 weeks. They were randomly assigned to the treatment of metformin with supplemental insulin if required. The metformin group, 46% or 46.3% required insulin. For neonatal complications, 32% of the metformin group had complications. And then for the insulin group, it was 32.2%. The neonatal hypoglycemia was greater in the insulin group, and then preterm delivery was greater in the metformin group. And there was no difference with maternal hypertensive complications, and participants treated with both metformin and insulin needed less insulin, and then there was less weight gain than those taking insulin. So this would be advantageous for patients that come into pregnancy who are overweight or obese. That were performed, and the outcomes were as follows. There were 42 other trials. Metformin was more effective in reducing neonatal hypoglycemia, macrosomia, or large for gestational age, preeclampsia, or admission to the intensive care unit. And then glyburide was more effective in lowering the risk of cesarean delivery. These trials had limitations because they were smaller samples and there were wide confidence intervals. Here is the Cochran review, which was a review for insulin treatment for patients with gestational diabetes. The randomized control trials, they had 53 studies, and insulin increased the risk of hypertensive disorders for pregnancy. There was no difference in the risk for preeclampsia between insulin and oral agents, cesarean delivery, large for gestational age, perinatal mortality and morbidity, development of type 2 diabetes, postnatal weight gain. So the conclusion is that there's minimal risks associated with the use of insulin and oral agents for the treatment of GDM, which is wonderful. Here's some information on metformin trials. So the evidence suggests that use in the first trimester does not cause anomalies. The low levels of transporters allowing it to enter the cells in the first trimester, which is great. So it's protective. But later in the pregnancy, the transporters increase. In the use for polycystic ovarian syndrome for the offspring, there were higher fasting glucose levels, higher blood pressure at age 8, and then a greater rate of obesity at age 4. And for the large randomized control trial, there's no improvement in miscarriage rates and not effective in preventing GDM. So if the patient takes it prior to pregnancy, it's not going to protect her against gestational diabetes. So we used glyburide, which is glinase, which is a second generation hypoglycemia sulfonylurea. This is started at 2.5 milligrams, either once a day or twice a day, and it would be given 30 to 60 minutes before breakfast, and then around 10 p.m. To control the fasting blood sugar and decrease the risk of nocturnal hypoglycemia. We can go up to 30 milligrams per day, and this may be necessary to establish the glucose control. We have to teach or keep in mind that this medication can cause hypoglycemia, so the patient needs to know the rule of 15. We want to continue to encourage the patient to eat the 3 meals and 3 snacks on time every 2 to 3 hours apart so that she doesn't experience hypoglycemia. And then glyburide can be associated with weight gain. So this might not be the best agent for somebody who enters into pregnancy overweight or obese. And then I did find some literature that suggested that glyburide before delivery may result in neonatal hypoglycemia. So you may want to consider having the patient stop the glyburide the night before she has a scheduled induction or a scheduled C-section to protect the baby. So here is the Metformin protocol. We didn't use much Metformin. We were more inclined to use the Acarbose and the glyburide. But Metformin is a safe medication during pregnancy. It is a biguanide that prevents production of glucose in the liver. And this will be used to control the post-meal blood glucoses. We usually titrated the medication because patients can end up with GI distress, particularly diarrhea. So we started with 500 once a day with breakfast for a week, and then we increased it to 500 twice a day with breakfast and dinner until we achieved blood glucose targets. The maximum dose recommended, we used 2,500, but the literature suggests that you can use up to 3,000 milligrams per day. We want to teach hypoglycemia prevention and management, although metformin generally does not cause hypoglycemia. We also encouraged and supported meal plan compliance to avoid hypoglycemia. And then the benefit of metformin during pregnancy is weight loss. So this is particularly useful for somebody that enters into pregnancy overweight or obese. And then metformin can be used by women who breastfeed. It does not cause low blood sugar in the infant. We had found through literature that patients that had the diagnosis of polycystic ovarian syndrome had more difficulty establishing breastfeeding successfully. So metformin was beneficial for milk production. So you might want to keep that in mind. So here is our Acarbose protocol. We used Acarbose if possible because we had 30% of our population was non-English speaking, and it was safer to use with communication barriers. So Acarbose is an anti-hyperglycemic agent, which is particularly useful for treating post-meal hyperglycemia. And research suggests, most recently in 2018, that Acarbose is safe, it's more convenient and less expensive. The starting dose is going to be 25 milligrams before each meal. The maximum dose can be up to 300 milligrams per day. There is little gestational weight gain, which is beneficial for those entering pregnancy overweight or obese. This medication by itself does not cause hypoglycemia. There can be digestive discomfort with this medication. Our patients complained of feeling gassy when they took the Acarbose. Acarbose can, however, cause hypoglycemia if you combine Acarbose with Glyburide. So you want to make sure that the patient is following the meal plan to reduce the risk of hypoglycemia. We don't want to give Acarbose if the serum creatinine level is greater than 2 milligrams per deciliter. Here is how the professional organizations treat their pregnant women with diabetes. As you can see, ACOG is going to use insulin as the first line of treatment and metformin as the second line of treatment, and then the alternate treatment could be Glyburide. The American Diabetes Association recommends the first line treatment as insulin and the second line treatment as metformin and Glyburide. The Society of Maternal Fetal Medicine recommends insulin and metformin for the first line of treatment and then Glyburide for the second line of treatment. And this is from David Kustan, Dr. David Kustan, an article written in 2014. And I actually had the opportunity to meet him at one of the diabetes and pregnancy conferences. It was a great honor.
Yeah.
I was grateful to receive information from one of your providers in Tanzania about the use of oral agents. So the first agent I was excited to hear that is Glyburide. This is, as you know, a sulfonylurea. It's a category C by the FDA. And we talked about the initial dosing of 2.5 to 5 milligrams once or twice a day, 30 to 60 minutes before meals. And the incidence of hypoglycemia is approximately 1 to 5%. Now for Glyburide, this is not anything that we use for pregnancy. It's used to help the pancreas make more insulin. It's also a category C. There are no well-controlled studies in pregnant women regarding the safety for the unborn baby, so we don't use it. Glyburide is used for type 2 diabetes, also a category C. This agent is not recommended during pregnancy or while breastfeeding. GEMA-2 is the combination of Glyburide and metformin. I couldn't find any safety data on this agent, but because it's a combo of Glyburide and metformin, I would not use it. Metformin we use in the US does not increase the risk of congenital abnormalities and is generally well tolerated when taken with meals. This reduces maternal weight gain when compared to insulin, and the use of this agent through delivery has not been associated with any hypoglycemia in the infant. So this is a safe medication. Discuss how we treat diabetic ketoacidosis in the inpatient setting. We will check our maternal vital signs on an hourly basis. We draw blood glucose, potassium, and an anion gap hourly until these lab values normalize. Then we drop it back to every 2 to 4 hours. We do continue maternal EKG and pulse oximetry to make sure that she is safe and to keep her fetus safe. We also continue external fetal monitoring if the patient is greater than 24 weeks. Otherwise, we're doing fetal heart tones every 4 hours. We don't want the patient eating anything if the blood sugar is greater than 300 or her anion gap is elevated, and we have a non-reassuring fetal status. Otherwise, she can have the carb counting meal plan for pregnancy. We do start IV fluids, 0.9 normal saline at 1 to 2 liters per hour over a 4 to 6 hour time frame. And then we follow our diabetic ketoacidosis orders. We need to be aware of the intake and the output of the patient. So we do use a Foley catheter. We do start our insulin at 10 units as an IV bolus. We use 20 units for severe DKA, And then we continue 5 units per hour of IV infusion. And then the goal is to try to normalize these blood sugars over a 4 to 8 hour time frame. When the blood sugar is less than 300, we change the IV fluids to D5 half normal saline, and then follow the intrapartum IV insulin algorithm. And then we always refer to neonatology in case, you know, we suspect that this baby is going to be delivered early. This is our intrapartum management for type 1, type 2, gestational diabetes, A1 and A2. We will give an initial dose of insulin the day prior to delivery. We DC the insulin at midnight, and then we keep the patient nothing by mouth until delivery. The oral agents, we give the initial dose the day before and discharge the day after delivery. The blood sugar is going to be checked every hour and then every 2 hours for a patient that does not require diabetes agents. Hyperglycemia, if the blood sugar is greater than 110 and less than 140 times 2, or 140, greater than 140 times 1, we would start IV insulin infusion. And then during active labor, we hold all insulin and keep the patient NPO until delivery. And then for the induction of labor, we manage the same as active labor. And if the induction fails, we're going to DC the Pitocin in time to give the usual dinner calories. And then we would be giving the pre-dinner and pre-bedtime insulin to establish blood sugar control. So here is the IV infusion protocol for active labor for type 1 and type 2 diabetes. We're going to check the blood sugar on admission, and then every hour we're discontinuing all sub-Q insulin. We're going to maintain a capillary blood glucose between 60 and 100. We want to start D5 normal saline at 125 milliliters per hour, the same time the insulin drip is initiated. We're going to have the patient NPO or non-carbohydrate containing clear liquids, and then initiate the insulin drip using regular insulin, 100 units per 100 mLs of normal saline, 1 unit per 1 unit, and then titrate the infusion per our algorithm. And the pregnant woman with A2 gestational diabetes requiring medication prior to delivery, she usually does not require any insulin during labor unless the blood sugar is greater than 100. Labor or induction of labor, we want to maintain the patient nothing by mouth and don't give scheduled doses of sub-Q insulin. If the blood glucose values become greater than 100, consider IV insulin infusion for hyperglycemic coverage. And then I did include the table for intrapartum insulin infusion, and it just shows you how many units of insulin per hour is necessary based on how high the blood sugar is. And once the insulin infusion is underway, the rates may be titrated based on individual response. We're going to modify the algorithm if the BG targets are not achieved within 4 hours to protect the mother and the fetus. So treating hypoglycemia during IV infusion therapy, if the blood sugar drops below 100 milligrams per deciliter, we're going to stop the IV insulin infusion. We're going to continue the D5 normal saline at 125 milliliters per hour. If the blood sugar is less than 60, we ask the nursing staff to call the attending physician, and then we're going to check the blood sugars every 15 to 16 minutes as clinically indicated, and then we're going to restart the IV infusion once the blood glucose becomes higher than 100 milligrams per deciliter. we're going to talk about delivery, cesarean section delivery. We're going to consider delivery of a C-section if the fetal weight is greater than 4,500 grams. We have to counsel the patient about risks versus benefits. We're going to try, if the patient is well controlled with the GDM meal plan, we don't want to schedule delivery before greater than or equal to 39 weeks. If the patient's well controlled with gestational diabetes with oral agents, we're going to allow the patient to deliver at greater than or equal to 39 to 39.6 weeks. If the patient's poorly controlled then we want to possibly deliver the baby at 37 to 38.6 weeks. Then again, thinking about risk versus benefit. And then if there's failed glycemic control in the hospital setting, we may want to consider delivery at 34 to 36.6 weeks. My maternal fetal medicine specialist leader discussed with me the difficulty when the baby is too big and can't be delivered. He feels like it is in the patient and the baby's best interest to go forward with the cesarean section. So for immediate postpartum management, the insulin requirements will decrease by 50 to 75% after the delivery of the placenta. So the biggest goal is to avoid hypoglycemia or extreme hyperglycemia. So our targets are going to be, the fasting blood sugar should be between 120 and 140, and 1 hour after the start of the meals, less than 200. So for the gestational, the patients with either A1 or A2, we're going to DC the IV insulin immediately after delivery of the placenta. She's going to resume a regular meal plan. We're going to be checking her blood sugars fasting and 1 hour post meal until discharge. If the fasting is greater than 100 or the 1 hour post meal is greater than 150, have the patient continue random checking until a 2-week follow-up visit. Now let's discuss the management of type 1 and type 2 diabetes in the postpartum period in the outpatient setting. We would like for these non-pregnant values to be fasting blood sugar less than 100, and then 1 hour post-meal less than 140. And we're going to counsel the patient to follow up with the healthcare provider at 2 weeks. And 6 weeks after delivery, we want to look at their blood sugars and make sure that that insulin has been titrated correctly and not causing either hypoglycemia or hyperglycemia. When I worked as the program coordinator at UC, I carried a cell phone, and all of our patients had my cell phone. So if they got into trouble one way or another, they would call, and then I could adjust their insulin over the phone. We counseled the patients about the advantages of breastfeeding. It is especially beneficial for the infant in terms of contracting type 2 diabetes later in life. We want to encourage family planning and provide counseling. And then we would discuss preconception diabetes self-management for the next pregnancy. Our goal for the patient before she got pregnant the next time was that her A1C was less than 6%, which is standard of care by the American Association of Obstetricians and Gynecologists. The breastfeeding blood sugar targets are going to be less than 100 for fasting, and the peak 1 hour postprandial is going to be less than 150 after the start of the meals. Discuss outpatient postpartum gestational diabetes follow-up. So what we want to do is reclassify diabetes with a 2-hour 75-gram oral glucose tolerance test. The new guidelines is between 4 and 12 weeks postpartum. And then the criteria for the diagnosis of diabetes after delivery is going to be a fasting plasma glucose of greater than 126 or a 2-hour plasma glucose of greater than 200. We want to counsel the patient about lifetime diabetes risks of 20 to 50% over the next 5 to 10 years. And it is going to occur more frequently in women with a family history of diabetes and among, the African American, Hispanic, Latino, Pacific Islander, Native Alaskan women. We're going to counsel the patient about the advantages of breastfeeding. We want to avoid all progesterone-only birth control pills due to the hyperglycemia effects, but strongly encourage the family planning. We want to obtain the 2-hour 75-gram oral glucose tolerance test and a lipid profile 1 year after delivery. Just constantly watching the patient to make sure that she has not contracted diabetes. If this test is normal, then we're going to retest every 3 years with a 2-hour and yearly with fasting plasma glucose. We want to do an early screen for gestational diabetes at the first pregnancy visit. We want the patient to try to establish weight control, continue physical activity, healthy meal planning, taking multiple vitamins with folic acid daily, and then also to practice stress management, because when patients are stressed out, their cortisol levels raise and their blood sugars become elevated. So breastfeeding is a wonderful way for the mother to decrease risk for herself and for her newborn. The American Academy of Pediatrics recommends that all women breastfeed for 6 months exclusively and then continue to breastfeed for at least 12 months. At least 12 months may reduce the risk of premenopausal breast and ovarian cancer and arthritis. 6 to 12 months may decrease the incidence of infectious disease, sudden infant death syndrome, childhood cancers, juvenile rheumatoid arthritis, and allergies such as eczema and asthma. For patients with type 1 and type 2 diabetes, this is going to improve her glucose and lipid metabolism. She wants to continue her carbohydrate meal plan, diabetes consistent carbohydrate meal plan, with adding an extra 500 calories over pre-pregnant level to make sure that she has enough energy for breastfeeding. Check blood glucoses prior to the breastfeeding, especially at night, to reduce the risk of hypoglycemia. So if the blood glucose is less than 100, we're going to treat with a protein and carbohydrate snack. Hyperglycemia is transmitted through breast milk. We want her 1 hour postprandial blood glucose target to be less than 140. We're going to teach the patient how to monitor for mastitis, because as you know, infection may cause high sugars. And then we're going to avoid progesterone containing birth control until lactation is going to be firmly established. There is our references for the information that we discussed. And I want to thank all of you for participating in this presentation. It has been an honor to share the information with you. I want to provide grateful appreciation to the University of Cincinnati Diabetes and Pregnancy Program in Cincinnati, Ohio, in the United States, and especially my partner in crime, Dr. Arthur T. Evans, who was the chair of obstetrics and gynecology, and then he is also a maternal fetal medicine specialist. I don't know what I would have ever done without his mentoring. It was very special to work at the university with him for 8 years. So we will welcome questions, and I will try to provide answers for you. And if I can't provide those answers, I certainly will try to email you when I get the information. Thank you again.
Thank you very much, Ms. Nancy. They received that diagnosis of gestational diabetes, and I'm taking my medication religiously. I'm eating right, and I'm doing everything I can. What are the symptoms that I could have to alert me to say, go and call the doctor or go to the hospital or do something right now? So what are the things that will happen to me for me to be alerted to notify the provider?
If they are not able to test their blood sugar to determine whether they're having highs or lows, I mean, I would want the patients to know the signs and symptoms of high sugars and the symptoms of low sugars, and that should be reported to the physician. And also fetal movement. I mean, the patient really needs to know about fetal movement after 24 weeks, because if she doesn't feel the baby move, she needs to be seen by a provider.
Okay. And I know you're going to get more questions when we have our discussion meeting with the other global experts. But the last thing that you want to tell a pregnant patient, like kind of your an overview, because you have a lot of experience about working with this population. So what is takeaway that the patient, just any patient, whether they're diabetic or not, just any patient's advice? Would you have anything to say for them?
With diabetes or not diabetes?
The people who are diabetic pregnant patients.
Patients with diabetes, they really need to be attuned to their body. Like I said, they really need to know the signs and symptoms of high sugars. They really need to know the signs and symptoms of low sugars to report to the physician. The fetal activity is very important. Any signs or symptoms of high blood pressure, maybe headache, maybe concentrated, very dark urine, can be, one of the complications of diabetes in pregnancy. All of that needs to be reported to the physician to protect the mother and the fetus.
Okay, thank you very much for your time, and QHSC team, thank you for your expertise and knowledge that you share today, where all our colleagues in Tanzania and around the world can benefit from the discussion. And I know some of the medication you suggested that we use here in the United States, they might not be using them in Tanzania, but we're going to request their participation, and so we can see which ones are possibilities, and if there's a need to introduce whatever is either affordable for people who they can access to get to manage their diabetes. So thank you very much. So stay tuned for second part, and I will post this video as soon as we can, and then so people will be able to see it. And then when they come to join us for the discussion, at least they've seen the video, and then if they have any question, then you can have a pointed question to specific content. So again, thank you very much for coming and spending time with me when we're recording this.
Thank you for the opportunity. I look forward to the second part of this discussion.
Thank you, Ms. Nancy. Okay, bye. Okay. Take care.
Okay, you too. Bye-bye.
Bye.
Drgaboneqhsc